Be going over the SJT, which is, I think, a very nerve-wracking exam for many people because it's quite different from what we are expecting. So we've got the Medical Education Foundation to hopefully go through that, guide us by the hand, and give us the right information to hopefully ace it as much as we can. Before we begin, just to talk about BiteMedicine very, very briefly, we have a question bank which utilizes a multi-step SBA platform. So you go through the patient experience from beginning, which is going to include your first steps, all the way from investigations, management to follow-up, and pathology therapeutic questions. We have a nice little neat textbook, which we're adding more content every day. And of course, we have these live webinars that we do on a weekly basis. So we have Dr. Miguel Campos, incredibly intelligent. He's an AFP doctor in plastics at the moment at St. George's, who's got a triple distinction from King's College London and has also been awarded the gold medal at King's. He's also completed an integrated degree in anatomy, and he's got multiple fellowships at Oxford University, Harvard University, and the National University of Singapore. And we have Dr. Callum Donaldson, also an AFP doctor at the University of Cambridge, graduated with a distinction from King's College London, and has been awarded the Cheselden Medal for the highest mark in final written exams. Dr. Ahmed Ghani, did I pronounce your surname correctly?
Yes. Yes.
Also an AFP doctor at Imperial College London. He graduated from King's with a triple distinction in MBBS and a first-class BSc in anatomy, awarded multiple prizes and the prestigious Wolfson in an integrated award, and the Hamilton Prize for the highest mark in the anatomy BSc. And Dr. Sachan Marathon, AFP at the University College London, graduated from King's with a double distinction in MBBS and a first-class BSc in anatomy and human biology, multiple peer-reviewed publications, and has presented his research in several international conferences. So we have a very strong academic bunch here today. So guys, feel free, whoever wants to jump in first. I'm not sure who does, but tell us about the Medical Education Foundation, what you guys are doing at the moment and what you intend to do in the next year, in the following year.
That's awesome. Thank you so much, Zach, for the introduction. Before I talk about the lecture again, not to rehash what you just said, but just to thank these guys at BiteMedicine. They're doing an amazing job. I've given a lecture with them before. It was a great experience. They've got an amazing, very smooth operation running. And I've had a look at the question bank that they've designed. So for all the students who are watching here now and are wondering, I often get asked, how do you do well in exams? I'd say questions are such an important thing. And the way these guys have designed their question bank, essentially taking you through the whole scenario, it's a huge improvement compared to just individual SBAs. So if you've got, if you've got the inclination, if you really want to go for it with regards to doing well in your exams, I'd advise that you have a look at the questions that these guys have created because they're very good, very, very high quality questions. All right, and thanks for the guys for having us here again. So today we're going to talk about the SJT. Just minimize the screen here. So a little bit about us as well. Zach kindly introduced the four of us. We got together about a year ago and we started this charity called the Medical Education Foundation. Essentially what we're trying to do is we're trying to combat some of the disadvantages that you often find in the medical education field, especially when it comes to applications. There's a lot of courses out there that are really expensive. At every stage you're going to have them. And so what we've essentially set out to do is to just provide a free alternative to all of those courses. So if you can't afford to pay or you don't want to pay, the expectation is that we run as a charity, so we get funds from big companies and we provide all the events for free. And hopefully the quality is just as good, if not better, than some of these paid courses. So I look forward to having you guys, at some of our events. It's all on Zoom now for the foreseeable future. So if you're curious about any of this, how you can see our events, go on our website, www.tmef.co.uk, and then there's a little button that you can click to subscribe to our newsletter. You can also follow us on social media. That's where we announce all of our events, sometimes in partnership with these guys at BiteMedicine. I think our values are very much aligned. So back today, what are we going to cover? The SJT is a situational judgment test. We're going to cover essentially what is the SJT, how does it fit into your whole application for the UK FPO. We're also going to address how it works for people who are applying for the normal foundation program versus people who are applying for the academic foundation program. The SJT is often a scary exam because it's considered quite high stakes. We're going to talk about, you know, how to prepare for it, how to really maximize your chances to strengthen that application, and any, you know, tips that we've had. We were wondering how to structure this question, this lecture in a way that was beneficial to everyone. And what we came to, I hope that you guys enjoy it because it was a bit of effort, was essentially, we're not going to give you each of the individual sections. We've structured the sections into domains. So we've got key domains that are tested time and time again in each of the 3 sections. We're going to, of course, cover the 3 sections and how you answer each of them. But we're going to, you know, the bulk of this lecture is looking at individual questions that fit into each of these core domains. So we're going to give you the theory for the core domains and then an example of one of the questions. So hopefully by the end, you'll have a pretty good understanding of not only what is the SJT and how does it fit into your overall application, but also how you're going to prepare and what type of theory and knowledge do you need to have. So again, the SJT for this lecture, we had to change it. We've given this lecture before and we had to change it quite a bit this year. The reason for that is the SJT's recently transitioned online. So you're going to sit it as an online examination. So even though you're going to see some of the paper marking methods later on in the presentation, we just left that on because it's going to be a good visual representation of how you get allocated marks, but it's all going to be online. And this is the link that you can follow if you want to have a look. You can also Google just, you know, UKFPO SJT, and you can find this quite easily. So this is one of the things, one of the novelties for this year. It's online. The second new thing this year is that it's there's a new section, a rating section, part 1. Before it was just 2 parts, but we'll touch upon that as well. And then they've also introduced a few new scenario formats that we're going to cover. However, I want to say that if you're taking advice from people who've said it before, like ourselves, if you're a bit worried about this being a new exam, just rest assured that this is essentially the same exam. It's testing the same key domains, it's testing the same concepts, and it's pretty much the same format. So there's a few nuances, but overall it's the same exam and you can prepare the same way. So this is what you're going to see when you sit the exam itself. This is a screenshot from the practice paper that you can find on this website. This is the new section, so you can see that we're going to cover at least one of these questions. You can see that you're asked to rate the importance of each of the considerations, which is slightly different from what it's been like in the past. And again, these are all individual elements of the same question on different screens. And these are the new scenarios, the new scenario formats that can come up. So evolving dilemmas, essentially it's a scenario that just evolves and you answer independently. But the idea is much like BiteMedicine have done with their MCQs, where you follow a scenario through to give you a better idea of what it's going to be like in real life. This is the same thing just for SJT. You get a scenario, you answer that question individually for this scenario, and then the scenario evolves and it continues. And the questions are, you're supposed to take them completely independently. The other thing is speech dilemmas. So how would you respond in conversation? So again, actually being there physically. And the third one is multimedia elements. Obviously the exam's transitioned online this year, so you can have videos which haven't existed in the past. So I think that's going to be a new one as well. So over to Callum to give you a little bit about the introduction.
Great, thank you, Miguel. So I'm just going to go through a bit about what the exam is, what it comprises, and how it relates to the General Foundation Programme application. So the SJT is 2 hours 20 in total, so that's 140 minutes with 75 questions to cover in that 140 minutes. So it's just under 2 minutes per question, which does make it a very time-pressured examination. And as I go on to cover, time really is key for this examination. It doesn't test clinical knowledge, so it's not going to be based on stuff that you've learned for your med school, your finals, your OSCEs. What it's looking to do is to test your judgment and decision-making in the clinical setting. However, it does test the knowledge of GMC guidance. So there will be some specific questions that you can only answer having had knowledge from the GMC guidance. So there's 3 sections, as Miguel's briefly alluded to. Part 1 is the new section, whereas part 2 and part 3 are the ones that have been in all the previous papers and are available in the old mock papers as well. So the 3 sections have slightly different focuses. Part 1 is a rate for options in regards to a given scenario. So you'll be given 18 scenarios in total of this type, and for each scenario, you'll be asked 4 to 8 response options. And these will be of a number of different formats, but rating the appropriateness or importance from most to least. And here, the different responses should be treated as independently. So each response should be different. You can use each option multiple times, or you can use each option not at all. For part 2, it's a selection type question. So you'll be given 8 options, 8 possible responses, and you should select 3 of the 8 together. So that's why this section is an and section, the 3 responses together that comprise the optimal response for this. And you'll be given 20 of this type of question. Part 3 is a ranking type question. So you'll be given 5 options, and here it's an or type section. So you need to choose the single best answer that gives you the optimal response on its own. So not together, not in combination, by itself. And you'll get given 37 of this type of questions. So the paper is split fairly evenly between the 3 types, and we'll just cover each one in a bit more detail now. So part 1, as we've mentioned, is the new section. It's the rating section, and there are 3 subtypes of stems that you can be asked for this question. So you can be asked to rate the appropriateness of actions, rate the appropriateness of things to say, or rate the importance of considerations. Now, Sachin and Ahmed will kindly cover some of the examples of these, but just in terms of how the section works and the marking, for part 1, this is an example of how we understand from the limited information they've given us, part 1 will be marked. So the maximum you can score on any given question is 4. Okay, so for example here, if the correct answer was A, then the top example, you've answered A here, you would get 4 out of 4. You then get -1 mark for every place away from the optimal answer you score. So here, if you've answered D and that was the worst answer, you're 4 away from the best answer, therefore you would score 1 out of 4. So from what we understand from the information given, if you answer this question, for every question you answer, even if you get the worst answer possible, you will score at least 1 mark. So part 2 then has 2 subtypes. So this is the or, this is the one where you select 3 of 8 responses that together give you the best option. 2 subtypes of stems, one of them being the most appropriate actions, and one of them being the most important considerations. And again, for this, we've got an example of how the marking works. This one we know for sure. It's happened many times over in the last couple of years. You get 4 marks for each question you correctly give an optimal response for. So for example, the correct answer in combination is ACE. Okay, so if you answered here ACE, you'd get 4 points for each one. That would be 12 in total. If you answered BGH, okay, so you've not got a single right answer there, you'd get 0 out of 12. Okay, so here the minimum mark for each question is 0. And then part 3, so this is the ranking of 5 options in order of the best to the worst. Okay, and here there are 4 different subtypes. You can be asked to rank the actions, you can be asked to rank considerations, you can be asked to rank the order in which you would do tasks, and you can be asked to rank agreement. Now here, importantly, the stems make a big difference. Stem 1, 2, and 4, if you didn't pick up the difference in the stem, you'd probably answer it in a similar way. But stem 3 is very different. Okay, so if you missed the stem saying rank the order rather than rank the actions or appropriateness, the answer order would be completely different. So in part 3, it's really important to pick out those stems which say rank order versus the other 3. And this is the one section where that really, really makes a big difference. In terms of the marking here, it's slightly more complicated. Again, we know exactly how this works. If you score the optimal answer, you get 4 points for every optimal answer you give. Okay, so for example here, the best answer is A, B, C, D, E. Okay, the example answer on the left has given this answer, it's the perfect answer. For each mark you've given, or each individual answer you've answered correctly, you get 4 points. That's 5 times 4, you get 20. That's the maximum mark for this section. The example on the right is actually the worst answer you can possibly give. Okay, so again, similarly to part 1, you get -1 for every place away from the correct answer you give. Okay, here, even if you give the worst answer possible, the minimum score you can get is 8. Okay, so similarly to part 1, where the minimum score is 1 out of 4 for every question you answer, here the minimum score is 8 out of 20 for each question you answer. So just by answering the question, even if you get it completely wrong, you're picking up a good number of marks, okay? And that's important as well. So clearly here, we should attempt every question because you're getting a good number of marks just for attempting the question. The only way to score less than 8 in any given question in part 3 is to leave blank ranks. So don't leave any one line blank, okay? And don't tie any answers, okay? So they should all be given in order. You shouldn't have 2 that are ranked 2, for example. So in terms of how the SJT works, you'll get a raw mark out of 1,040 in total. And then that's mathematically scaled to give you your SJT score, which is the bit that contributes to your foundation program score, out of 50. And there's a common misconception among a lot of people that the SJT is weighted way out of proportion to your EPM. So the minimum EPM, the educational performance measure score you can get, as I'm sure many of you will know, is 33. So that's if you're in the bottom decile for your university, you have no extra degrees and no publications. However, if we look at the graph on the right, the way in which the SJT mark is scaled, 95% of candidates will score between 33 and 50. So for the vast majority of people, the SJT will contribute in equal proportion to your foundation program score as the EPM does. So this scaling gives them an equal weighting. One thing to note about the previous graph is that there was quite a lot of clustering around the mean score. And this happens because it's very hard to score particularly low or particularly highly on any given item. So as we mentioned, the minimum score for part 3, for example, is 8. Even if you get just a couple of questions in vaguely the right place, you're going to score 14 and 16. And this means that a lot of people score a very similar mark. So last year, 80% of the raw scores were between 860 to 930. And remembering that this is out of 1,040 in total. That 860 to 930, when it was scaled to give you the out of 50 score, converted to a difference of 36.25 to 46.12. And that means that just 70 raw marks on this examination were the difference between you getting a 36 and a 46, okay? So to equate that, that's about the equivalent of 3 part 3 questions. And it's why it's so important that you must answer every question and you must finish the paper. Because if you don't, it's the only really easy way to lose a lot of marks and score badly. If you finish the paper and you finish it on time and you answer every question, most people will do well. So just to cover a couple of the common questions that people often ask about the SJT. So is there a correct answer? And I think to understand this, you probably need to realize or understand how the questions are created. So the whole examination is based on foundation doctor core domains from the GMC medical guidance. They will pick a certain core domain that they want to test, and they will create a question based around this core domain. They will then produce 5 possible answers to the question, and they give this to a panel of so-called experts, which in practice is a mix of patients, senior doctors, junior doctors, and they ask them all to come to an agreement on what they think the best ranking or best order of those options are. Once they've got that concordance from an expert panel, they then pilot it amongst test students. If there is a big difference between students in what they think the correct answer is and what the expert panel has decided is the correct answer, then the questions aren't used. However, if there is a reasonably good concordance between the two, then the questions make it on to next year's or future exam papers. So what this means is there is no definitive set of rules that can be applied to yield the correct answer every time, because actually the questions are a factor of expert opinion, and any given explanation or rationale, even in the official foundation papers, are somebody simply retrospectively going back and trying to explain the reason or the why the experts answered the question the way they did. However, it is a robust process to ensure that the answers are fair and they represent widely held opinion on the question. So can I fail the SJT? The answer is yes, but only for a very, very, very small number of people. So in the handbook in previous years, this has been named as an exceptionally low score, are the exact wordings they use for this. In reality, this is, in previous years, correlated to about the bottom 0.5% of candidates, sorry. So it is really a very small amount. It is worth noting, however, that this is the only way in which a situational judgment test impacts the academic foundation program application. So the score itself, as many of you will know, I'm sure, does not affect the AFP application. However, if you fail the SJT, if you get in the bottom 0.5%, then your application is also withdrawn from the AFP program and you can't take up that post, even if you're otherwise successful in getting it. However, in practice, as we've covered, you're very, very unlikely to be in that bottom 0.5%, and it's very, very unlikely to happen. Okay, and finally, can I prepare? So I think absolutely yes. It's not an exam you can necessarily revise for, but you certainly can prepare by good practice. And just in terms of how we'd probably advise going about that, we've got a couple of example resources here. So the absolute key is the practice papers that are available online. So there's now 2 previous practice papers in written format from previous years that have example questions from part 2 and part 3. And there is now a new version of the online exam that includes part 1 as well from Pearson VUE. The answers and rationales that are available for the previous 2 papers are absolutely worth going through. And the logic there is really useful, as similar questions will come up in the examination. As we covered, the only knowledge you need for the examination is the good medical practice. So this document is absolutely worth reading, as there are sometimes questions that you can only answer by having this knowledge. All other resources are then somewhat optional. Some people find them useful, some people don't. At the end of the day, all the core information, everything you need to know is in these 2 documents. Some people find courses available. There are a number that you can attend. Some people also used to find books, and some people do use online question banks as well. And there are just some examples of these here. The important thing to note is that these questions have not gone through the same rigorous process as the official papers, and any logic may be dubious that they give as example question answers. So it can be useful to use these resources maybe to help you think about how you would answer it. But if you're going to use them, absolutely don't take the answers they give or the logic they give as gospel, as in many cases, these actually directly contradict questions that are found within the official mock papers. Thank you. I'm going to hand on to, just to cover then what we've said very briefly and sum up kind of the main tips from this section. Timing is absolutely key to this examination, okay? Every question, you get just less than 2 minutes to answer. It's very, very important you answer every question, and missing even a couple of questions can make a massive difference to your score. You should answer the questions in a should, not a would manner. So not would, what would you do in clinical practice? It's what the optimal response would be, what you should be doing. Read every question carefully. There are different stems for each different part, and particularly in part 3, just picking up on what type of stem is being asked can make a big difference to the way in which you answer the question. Think about how you should be answering the question. So part 1, every response is individual. Part 2, you need to think about them as an and part 3, think about them as an or. So are they being taken together, or are they being taken separately, the answers that you're giving? And finally, the best way to prepare is using the GMC ethical guidance and the official situational judgment test papers and online mocks. So thank you. I'm going to hand over to Satya now just to go through some of the core domains that are tested within the paper.
Thank you, Callum. So as Callum mentioned, I'm just going to go through the domains and the frameworks that are useful and are commonly tested in the SJT. As Callum mentioned, one of the best resources is the Good Medical Practice, where they will outline all of the domains and all of the guidelines, and that's definitely worth reading. However, it's impossible for me to go through every single guideline, so I'm just going to go through the main things that come up in the recurring themes and what, from the previous practice papers and our experience, what I think you should focus on in each of these domains. This paragraph is taken exactly from the website itself, and just to highlight the main key points that are important here. So all of these situations are for you as a foundation doctor. So you should place yourself in the position of an FY1 and how you would act in these situations, and your ability to recognize the most important concerns and the most important issues that arise from the stem of the question. Once you identify these issues, it's important that then you are then able to choose the options that represent the most appropriate behavior and the actions that you take in regards to making sure you maintain patient safety and also harmony within your colleagues, and you're working in a good team environment, as well as managing your own workload. As you can see, there are usually loads of issues going on in any one question. And the SJT is really difficult because it asks you to rank which one is most important. And so we'll go through the domains and see which one is, which issues crop up the most. The test itself covers these 5 main domains, which are based on professionalism, coping with pressure in a team environment, communicating with colleagues, both medical colleagues and other healthcare professionals, whilst always maintaining the patient as the main focus and working together as part of a team. So I just want to, before we go on to the main domains, just go through the medical team and the team members that are involved, as these kind of terminology keeps cropping up, and it's important to know what these members do and what their roles are. The clinical director is usually the most senior clinician in a team, and he's responsible for all of the consultants and all of the services provided by the team. The educational supervisor is usually a consultant who's responsible for supervising junior doctors, and he usually takes on this role for over a year, and usually it's based on pastoral care. There's a similar, most universities employ an educational supervisor for medical students just to get them involved and get them used to the kind of setup that you have as a doctor. The clinical supervisor is also a consultant, but he's more responsible for the clinical activities of the junior doctor, and you can expect to see them on a day-to-day basis, whereas the educational supervisor, you would perhaps have monthly or meetings every rotation. A specialty trainee or a registrar is the next senior most member below a consultant. And then below the registrar, you have what previously were known as senior house officers or core trainees, FY2s, and of course the FY1 yourself. And you're also expected to have medical students below yourself. The nursing team is also very, very important, and it's really important to know their roles within the team, especially as several of these questions involve these roles. So compared to the clinical director, there's always a senior nurse or a ward manager who's responsible for the ward and all of the nursing staff. There's specialist nurses who have very key skills in a specialist environment. So for example, you can have emergency nurse practitioners, hepatology specialist nurses who have very key skills and an interest in a specific area. A nurse or a staff nurse are nurses that you see on the ward caring for a set of patients or a bay. These nurses are responsible for the day-to-day activities, responsible for administering medications, taking observations, and highlighting any issues to the doctors. And healthcare assistant is an aid for the nurses mainly, but also involved in key processes as involved in medication and observations. So ethical principles form a backbone of any kind of discussions that you have in the SJT in all scenarios. I'm sure you guys are quite aware of this before medical school even, thinking of the main 4 pillars: autonomy, involving the patient and patient's choice, making sure we get the patient's wishes and get consent; beneficence, always acting in the patient's best interest; likewise non-maleficence, making sure we don't cause any harm and making sure everything we do is within the patient's best interest and not going to cause any adverse effects; and justice, especially within the NHS, always have to make sure what we do is fair for the entire society and for equal sharing of resources. So I just want to remind you of the duties of a doctor before we get stuck in with the domains. What should come paramount is patient safety and patient care, and addressing their concerns or their safety at any point. So whenever you see something that impairs this in a question, this should always highlight to you that this is one of the main issues that you need to be identifying and reacting to. Promoting the health of the patient and the public is also a very important task of a doctor. This goes in with being professional, not just in the environment that you're based in the hospital, but also outside, and setting an example for all the public and patients families. Providing a good standard of care for all patients, treating patients with dignity, being professional, being honest, and also acting with integrity and remembering your duty of candor. Working well within a team is obviously really important, as we're always working with members of our own clinical team and also with other healthcare professionals. So basic principles when it comes to answering these SJT questions. These principles can be used across all of the questions, across all of the sections. Even though there is a new section, the principles behind answering the SJT question is the same across the board. Always, after you identify the issues that are cropping up in the question, the best answer would always be the answer that directly addresses the question and the issue in the question and addresses it safely. If you find an option that addresses it directly and safely, this will be more preferable to an answer that only addresses the safety aspect, but somehow does it indirectly, or vice versa. So once you identify this, this is always, almost always, the best answer in the question. Thinking about the time course of the actions and the responses is also very useful. Depending on the issue, it might need an action that immediately rectifies the issue, or it might need something that takes much longer. And so you might need something that's a more long-term solution. So depending on the question, the time course can also be quite useful in helping you determine what option to go for. The next point, the severity of the answer should be proportional to the severity of the scenario. This goes without saying. If someone is really unwell, then something you need to do, it has to be significant enough to help make sure the patient's safety is not compromised. As I mentioned before, direct actions are always better than indirect actions, and we'll go into more detail in the domains before. Doing nothing does come up as one of the answers, and sometimes it's usually the worst answer. However, if there is another answer that brings about unavoidable harm directly to a patient, then obviously in this situation, doing nothing is better than causing harm. Again, this depends on each question, so I wouldn't assume that doing nothing is always the worst answer. And the last question, if patient safety is not at immediate risk, this usually applies to questions that involve team conflict or conflict within patient family members, things like this. If the patient safety is not at immediate risk, it's always better to gain more information around the situation rather than jumping in and trying to tackle an issue without fully knowing the entire story. I'll go into more detail in the domains when it comes up. So confidentiality is a very common aspect that comes up quite a few times within the paper. And I'm sure you know, the patient's right to confidentiality must always be protected, and we shouldn't do anything that risks leaking patient information. There are some situations where you might be required to disclose confidential information. In these situations, always seek senior support and the help of others before releasing any information. There are some situations where it's a legal requirement, for example, any notifiable diseases, or ordered by a court. Or there may be situations where there is serious risk of harm or death to the patient or any other members of public, and you may be requested information by the police or other legal authorities where you have to disclose this information. So again, for these kind of situations, always gather senior support before acting on your own, especially as an FY1, you might be quite junior in the team and may not be the most experienced member to take this discussion on. If another member is found to be breaching confidentiality or breaking any of these rules, it's always better, as I said before, to directly inform the colleague so they are aware and they can make any necessary actions to rectify what they've done and also learn for the future. Instead of telling your senior directly without telling the member, this will just not allow the member at fault to directly realize their mistake, and you also risk them repeating the mistake. I've put a line here just to show you what's more important. Patient care always comes first, and then it's patient confidentiality, and then any other concerns about relatives or other patients always come below patient confidentiality. Moving on to prescribing. Prescribing can be quite an important issue, as prescribing errors can lead to patient safety being compromised. Never prescribe anything that you're unsure about either the indication or the dose or the regime. You should always assess for yourself and never listen to other people telling you what to do if you're not quite sure. Any issues that you have with prescribing can always be asked by either a senior doctor or a pharmacist. And if you have a question that asks you to, where a senior doctor asks you to make a change in the medication, and if you're not comfortable doing so, it's always better to ask someone equally senior as the patient, as the doctor, or even ask the doctor themselves if you feel comfortable doing that. Usually, asking the person directly can be a better solution than asking a pharmacist. But of course, asking a pharmacist does come before prescribing an unsafe dose. Any prescribing errors that you make, again, must be discussed with the patient. As I mentioned before, that forms part of the duty of candor, being completely honest about any mistakes that have happened, even if there was no harm as a result of the error that was done. Patients have a right to know what has happened, and also have a right to know what you're going to do to make sure these things don't happen again. It goes without saying, make sure you check patient allergies before prescribing anything. And as an FY1, you're not allowed to prescribe any cytotoxics or any drugs like methotrexate or any chemotherapy drugs. So if there is a question saying asking you to prescribe things like this, please make sure you don't pick the option that says do not prescribe. Guidelines such as this are all present, or you can all find all of them on the Good Medical Practice Handbook. So obviously it will be useful to read that before you do these practice questions. Discussing communication and teamwork, goes without saying, always try to work well within your team members. Try and pick up slack where there is, and obviously work within your own limitations. Does not mean tire yourself out. Make sure you can get on top of your workload and also help other members first. If any issues do crop up within your team, always try and deal with it directly, as I mentioned before. Speak to the other member and try and sort out the issues before escalating it within your seniors. However, if you fail to sort it out directly, then the level of escalation should be appropriate. So you should always go to your senior house officer first, before going to the specialty trainee, clinical fellow, or registrar, before going to your consultant. Distribute workload equally, and if you find that other members are not picking up the workload as much as you are, then discuss it with them, and then discuss it with your educational supervisor or clinical supervisor to see if you can make any rectifications regarding workload. Try not to be aggressive to your team members. Any kind of aggravation or conflict will not look good on the SJT. Regardless of your workload and your stress levels, unwell patients will always be your priority unless there is a situation where you are not able to focus or not able to make good decisions that can impact other patients' safety. In those kind of situations, it's always important to escalate this issue so that patients can be looked after, and then any other clarifications regarding your workload or your stress can be dealt with later. Just going to touch on issue on capacity. Again, more detailed guidelines are found in the Good Medical Practice. Adults all have capacity until proven otherwise. If they don't have capacity, then you can carry out a formal capacity assessment. Children under 16 are assumed not to have capacity. However, you can assess these patients via the Gillett competence methods. And if you do feel they have competence, they have the capacity to make decisions, then they do have capacity. However, just to make sure, all capacity decisions are specific to decision and time. So capacity can change according to what the decision is. And of course, if someone was proven to have capacity a week ago, this does not necessarily mean they still have capacity now. So you'll have to reassess this. In terms of consent, FY1 should not consent for procedures, or any doctor should not consent for procedures that they cannot perform themselves or fully answer the questions regarding both the risks, the benefits, and the purpose of the procedure. For example, taking blood tests, FY1s can consent for that. However, this not usually, you don't have formal consent, but informal consent is usually observed and gained before making any procedures. So things like performing surgery, clearly an FY1 will not be able to consent patients for this. Even if they are pressurized by their seniors, all doctors that are not capable of performing the procedures should refuse to consent these patients, because this can result in patients being misinformed of the risks and the procedures, of the benefits of the procedures, and can lead to harm. All patients should have capacity before they can willingly consent, and all consent must be voluntary and not forced. Mentioned slight earlier before about managing workload. Doctors to try and have equal workload between themselves, try and manage their stress levels and have enough hours of rest, both during work and between shifts, just to make sure the main priority is that patient's care is not compromised. Having unsafe working hours with very limited amount of rest, or working several night shifts in a row beyond the safe recommended amount could make your decision-making compromised and put patient care at risk. Finishing on time is quite a priority on the SJT. It does quite come up in a few questions, and the GMC like doctors to finish on time, as this shows good work-life balance and that the wards are well staffed and the work is not overwhelming for the doctors. If you do have any urgent jobs, try to hand over. However, any jobs that can be completed in the daytime tomorrow and non-urgent should not be handed over. Only stay late if there is a patient that is severely unwell and no one else is there to look after, and you are required to look after for the patient's sake. Again, as I mentioned earlier, if the workload is getting too much or you find yourself being too stressed that you can't focus clearly, please escalate this and raise this as an issue so you can discuss this with your seniors and make sure any kind of modifications to the rota or the workload can be made to ensure you and the patients are kept quite safely. Do not take sick leave just because you are stressed. Sick leave should be kept for periods where you are actually unwell. Taking sick leave just to relieve stress does not address the actual issue at stake. And so issues should be discussed with the senior without you trying to shy away from the issue. Social events such as evening commitments should not determine whether you leave on time or not. As I mentioned earlier, patient safety and unwell patients should be one of the only reasons that you leave on leave after work. Raising concerns, as I said before, any issues that you identify should be raised directly to the patient, to the person involved without making it confrontational. And so you can both work towards solving the issue. If this does not prove to be helpful, then of course you can always escalate it to your seniors, and the seniors can help, especially because they're more experienced and probably have more information to help you make the right decision and get to the right outcome. And in certain situations, asking for more information about the issue can sometimes be more beneficial than resulting to an urgent correction or an urgent confrontation. Any issues or concerns regarding the behavior of your MDT or other members should not really be dealt with the FY1. Given the level of superiority involved, getting more information and getting senior support might be a better idea than directly approaching, for example, a senior nurse on the ward. Professionalism. I'm sure you've all have had several talks on professionalism throughout medical school. And again, these things stay the same once you're a doctor. Try to be professional both in the environment you're in and also outside of hospital. Don't engage in any friendships with patients or patient family members. Everything should be kept strictly professional. And there are some questions where patient family members try to get in touch with you via social media or try to get in touch with you gifts and monetary gifts. Try to stay away from all sorts of things like this. And it's always thought to be better to ignore a message on social media rather than respond to it, as this can sometimes lead to further conversations and can be seen as initiating conversation. Do not accept referrals from your friends or family members. Always point them in the right direction of the proper way to get medical referrals via GP or via A&E. Being a doctor, you're in charge of the patients you're in and not necessarily for your family members. As I mentioned, handover can form a key part in medical teams. Handovers usually take place in the morning and the evening, and it's a period of transfer of care or information about patients from one team of doctors to another team of doctors. Usually this should be done face-to-face, but sometimes this cannot be possible. And in these kind of situations, another doctor in an equal position is much better in terms of accepting the handover rather than a written or a non-verbal verbal handover to another member of the team, such as a nurse, for example, And this is not preferred, as a handover should be to a doctor or a nurse to a nurse, and there shouldn't be any kind of overlap between nurses and doctors. This can lead to some jobs being slipped through the net and can lead to patient safety being compromised. The SBAR format of handover should always be used. You might have come across this in medical school, where this basically involves the situation, the background, the assessment, and any recommendations or what response you've done. As I mentioned earlier, urgent jobs should be handed over. Non-urgent jobs should not be handed over to teams on call or ward cover members, as they are extremely busy anyway and are there to attend to emergencies and not to do menial tasks that can be done in the next day just because the team on the day today did not manage to finish them. With regards to discharge, FY1s cannot discharge patients themselves without any kind of senior supervision support. So you can get information from other doctors, such above an FY2 or above. So if these doctors phone you and ask you to discharge a patient, that's acceptable. If a decision is made on the ward round and is documented, then that's acceptable. However, FY1s should not make decisions by themselves without getting senior support. That's the section on domains finished. Now I'm just going to hand over to Ahmad, who's going to go through questions from these kind of domains and ask.
Okay, hi everyone. So myself and Miguel will be talking about a few questions, practical examples from the actual foundation program website, and be talking about the different domains and sort of going through the rationale for some of the answers that they give. Now, there is a new online paper that they've released this year, which we do have example of, but because they don't release the answers, we're just going to sort of just discuss it quite briefly and then go on to the actual questions where they do have the answers and rationale, so we can really go through what they're thinking and what you should be thinking as well about what they ask. So I've also sort of split it into different domains that Satchan just mentioned. And of course, there are going to be a number of different domains that the questions do tackle. But it's important to think about what the question is really referring to. So this is an example of the question of a rating style question, which is the new kind of question that was introduced, has been introduced this year. So because they don't give answers to it, I'm not going to dwell on the answer too much. But I just want to point out a few key things about these question types. So you get a stem, a question stem, and you can probably see for this kind of question, it's talking about confidentiality, and also about colleague relations as well. And then you're given different options, different questions, and you have to go through them and sort of rank them on their appropriateness. And these kind of, so this is the next question. And I think what's important about this question that we want to discuss is don't answer them dependent on what you answered other questions. So they're kind of independent questions. So if you think something's very appropriate, don't be scared to say the next one's very appropriate if you think it is. They're not related. So answer each question independently. And this kind of also ties into what Miguel mentioned earlier on about these sort of evolving dilemma scenarios, where you have to answer questions on an initial question stem, so this part A, and then they give you another scenario sort of escalating from that initial sort of escalating from that initial stem, and ask you different questions about that. So it's definitely worth going through these questions. I'm sure they will release the answers, and it's worth going through them. But again, I don't want to dwell on these just because they haven't given the answers, and we have a lot of different questions to go through with the actual answers. So another question about confidentiality. So what I want to do with these questions is I'll give you sort of 30 seconds to a minute to read through, and then maybe you want to write down, in the chat or at home, sort of what you would say. So this is a confidentiality question. It's a ranking question. You have to rank the appropriateness of the following actions, and then we'll sort of discuss the answers.
Omar, I'm wondering, maybe I should try and put up the chat here. See if people answer on the chat.
Okay. Yeah, that sounds good.
Can you see my chats here?
Yeah, I can see it. I I put it up as well. Don't worry. So yeah, we'll be given the answers to these questions, the ones we're going to do now, because they have the official answers. Okay, so what I want to say about these questions, these ranking questions, and a way to tackle them, what I would recommend is always try and decide quickly the best answer, the most appropriate answer, and then the least appropriate answer. The reason for this is because the way it's marked, if you get those two right, the most appropriate and least appropriate, then you score at least 16 out of 20 marks, just because of the way it's marked. And then the middle three, which are often more difficult to rank, you can sort of decide in any order, and you still get at least 16 out of 20, likely 18, and maybe even 20 out of 20. So for this kind of question, I would always try and decide, okay, what's the best answer? And then, okay, what's the least appropriate answer? So I see someone's already discussed, so let's just move on. So great, AM. So that's the order. So if you see, the best answer is C. Tell Suzanne politely but clearly that you can't tell her the results. And that's the best answer because it first of all enforces, sort of reminds her about the requirement of confidentiality, which is the crux of the question. And you're also doing it in a sort of polite way. You're not antagonizing anyone. And then if we go to the least appropriate answer, it's option B, because you're just telling her the results, and that breaches patient confidentiality. And then you've already decided those two, and then you could decide the ones in the middle. So senior input is always advisable. Exploring Suzanne's anxieties is always a good option. Exploring anyone's concerns is always good. But in this situation, it doesn't quite address the issue of confidentiality. Okay. So that's sort of the way I would be thinking about this question. Okay, so let's move on to another question about prescribing now. So again, I'll give you another 30 seconds to a minute. Okay, I think that should be enough time. Yep, so we're getting some answers. So yeah, very close, guys, and that's absolutely fine. Again, you've decided, the best and least appropriate answer. So the best answer is explaining to the doctor you're concerned about prescribing the drug. And, in these situations, when you have a concern about something, it's always good to directly approach the person involved and approach them in a polite way and express your concerns. And then the worst answer would be to prescribe the drug, because that's an issue of patient safety and you're risking, an allergic reaction by doing that. So never do that. And then the ones in the middle are, you can debate, okay? So again, I've discussed the first and last answer. And then in the middle, I see there's some debate in the chat about, the nurse over the doctor, and that's understandable. It is quite a difficult question. The way they've explained it here is that, first of all, speaking to the pharmacist as the second best option, because they can offer independent advice, and they also, they are aware of patient drug reactions. The nurse has a responsibility for giving the drug. So that's, as AK mentioned, they're directly preventing the action, which could cause harm to the patient. And then talking to another senior doctor is a reasonable course, but they say that it introduces another opinion, I think this is quite debatable. And again, it's really good that you guys are thinking about this, and it's a really good thing to question. And again, you will have these things when you answer these questions, but again, you will all still score at least 18 out of 20 or 20 marks, which is what you want in these questions. So, I wouldn't dwell on this. I would just focus on what they're saying and sort of take that forward in other questions. Okay, so I'm just going to move on for just the interest of time. So again, prioritization is another topic that's been mentioned before. And again, if you want to read through this question, this is a 3 of 8 question, which is section 3, part 3 of the paper. Okay, so I see some answers. So, yeah. So yeah, the answers B, D, and E. So very close AM, but so in terms of this one, the best answer is the one of the answers is B. So you ask the healthcare assistant to hand over to a nurse, which is appropriate because nurses can speak to patients and give them updates. It's only if they have a clinical issue, then you can talk about that. D, which discusses sort of handing over the non-urgent tasks, which is what you would do as a doctor. And you will be in this situation as an F1. You will have loads of things to do at the end of the day, and it's up to you to decide the most appropriate things to do with the most urgent clinical tasks, and handing over the rest of the tasks you have to do. And then E, asking for an F1 for help. That would also be appropriate because you're working as a team to get things done. So in these questions, the 3 of 8, what I would really stress is you pick the 3 answers that work well together. So they don't have to necessarily be talking about the same things. They're kind of 3 separate answers that when you do them all, they would answer the overall question. So that's how I'd sort of approach those questions. Okay. So patient safety now. Sorry, I'll give you more time. Yeah, it's just that we're a bit pressed for time at the moment, but yeah, I'll give you a bit more time. Okay, I think we have a few answers now. And I think you all are agreeing or very close to each other, which is a good sign. Yeah, so B, A, C, D, E, which I think is what most of you had. I think some of you may have had 1 or 2 different, which is absolutely fine, because you still get 18 out of 20, which is absolutely fine in this situation. So again, this is about patient safety. It's sort of similar to the last question, but it's more about you staying late and affecting your health or patient safety. So again, this is about what the most important considerations are. So as a doctor, your primary concern is patient care. That's what they say in the GMC guidelines, and that's right. Then your own health has to be looked after. So those 2 are the best. The worst answer is disappointing your friends. Although it's important to have a work-life balance, the SJT won't really consider, you know, the need for you to go on social occasions. So that's probably the least important in this situation. Yeah, who needs friends, right? And then in the middle, you have finishing on time, which you should be doing as much as you can. But if it affects patient safety, if you have urgent tasks that you need to be there for, then, you know, you have to stay for those. And then getting a poor reference is still, it's not as important, but it's still important in sort of a professional sense in this situation. Okay. So again, it's all about ranking those answers, choosing the best and worst answer, and then the ones in the middle, and you'll score well. Yeah. Yeah, so now I'll pass over to Miguel, who will just take over the final few questions.
Thanks, Ahmad. I'm just trying to figure out how to turn my video back on. Where is this? Sorry, guys.
It's in the bottom left.
There we go. Yeah.
Yeah.
Does that work? There. Right. So just very, very quickly, thanks, Ahmad. Thanks all of you. Actually, that was really good. I can see that there's some questions in the chat. I want to leave questions to the end. There's just a few things that I was looking at now, and I just wanted to very quickly bring up. Some of you guys were asking about the mock paper. Could we have the mock paper, the link to the mock paper? It's on this presentation. I suspect you'll be given a copy of the presentation. If not, it's extremely easy to find. You just literally go on Google and type, you know, UKFBO, SJT, and you'll be able to find it quite quickly. The other thing I wanted to mention is something that's come up is there was a lot of debate in the chat about questions and subtle nuances. I wish I could tell you it's going to get better, but from experience, I think all the other guys might agree with me, it doesn't really. Right up until the very day that I sat the SJT, I still didn't agree with a lot of the answers, and I find it very difficult to sort of justify them in my head, which is why I think it's so important, and that's why Callum gave you the advice. The best thing you can do is do the official mock papers. And what I did, and what I think a few of these guys did as well, is towards the end, at this stage now, early on, you guys are many months before your exams, you're absolutely fine to just start thinking about these concepts, right? Reflecting in your head, reading different books and things. But as you get closer to the exam, my top advice to you would be to just really focus on these mock papers. And even if you don't agree with something, try and convince yourself as to why. Because unfortunately, as Callum said, there is some consensus. The people who came up with these examples, there were a panel of consultants and, you know, other healthcare staff who got together, and they're used to working in the clinical environment, and they all discussed these answers. And if the question's here, it means not only that they agreed, but also that this was likely piloted in a previous SJT, and that the response to this question equated with the overall score of candidates who did, you know, it was a good differentiator for candidates. So these questions have gone through a lot. It's, you know, I still don't agree with a lot of them. I don't think many of you will, but I do think that it's quite good to just get yourselves in that mindset. Before we go through these questions, I just want to remind you of what Callum mentioned. Number one, should not would. This is what, not necessarily exactly what you would do, but this is, you know, if you're stuck in a scenario and you're thinking, I really don't know how to rank these two options, there's two things that would really help me. One, if I was the model F1, if I was the perfect F1, what would I do? You know, if you try and imagine the best F1 you've ever met, this is what this person would do. And the other, if you're really, really stuck between two options, as Ahmad said, the best is to get the first one and the last one in the right place. The rest is sort of interchangeable. But if you're really, really stuck, I would like to imagine this question was on a balance. So how much harm is this option going to cause versus how much benefit? And actually, if you've got two things that appear pretty similar, but one of them might cause harm or the other one might cause benefit, then it'll make it a lot easier to come down with your answer. And I know that sounds like simple, but when you're actually going through the examples in your head, if you go through that little exercise, obviously quickly because you're pressed for time, it should hopefully make things slightly easier. So that was a sidetrack. I digress. Let's go back to the scenario. This is a difficult colleague scenario. I can see we've already got some answers, but some of you might have been listening to me. So I just want you to quickly have a read through. I'll give you about a minute just to read through the options. Yep, I can see quite a few answers. Hopefully that's good enough. So the right answer is ABEDC. Okay, let's talk about why. So if we go back to the question itself, when it comes to one of these scenarios, I'll just move this chat out of the way. It's always best to speak to someone directly, okay? And the way that the question is phrased really makes a difference. So if question A, which is the best option here, says, speak to Robert about your concerns, okay? That's something that's very, you can imagine that happening. It's not confrontational. If it said, obviously the step number one from what Sachin said to you guys is try and speak to the person directly involved. Avoid a chain, avoid bothering people. People are busy with their own lives. So try and go directly to the person who you're speaking to. So we know that Robert is likely going to be the best option. But if it said, argue with Robert about your concerns, then that's the way it's phrased makes it less ideal. So really pay attention to the phrasing. So number one, we know why that's the correct option, because you're speaking to someone directly and it's phrased in a nice way. So speak to Robert about your concerns. Good. Discuss the distribution of tasks with your educational supervisor. Why? Because they're responsible for your pastoral sort of ongoing development, as Sachin mentioned to you guys earlier. They're the direct link, the direct chain. If you're feeling really overwhelmed with work, you don't have time to do anything else, you're not meeting your educational requirements, you can discuss this with your educational supervisor, and it could be that they've got some advice. So that's the next best one. Then discuss with another F1 colleague. Again, you could do that. It's somewhat passive in the sense that you're just discussing the situation. Again, it could be they've got some advice, but it doesn't directly really address the situation at hand. And then the other two, D and C, one of them is complain. So you can see that it's phrased quite negatively. So complain to the ward consultant. Yes, the ward consultant is someone who is likely relevant because they're in charge of the ward, but the way it's phrased, you're complaining to them. It's less than ideal. And the last one, report the unfair distribution of tasks to Robert's educational supervisor. Now, the reason that's probably the worst is because you're essentially going behind Robert's back and just bypassing the whole thing. You're going to someone who isn't even working on the ward. Their educational supervisor could be a consultant who's in the community or whatever it is. You're essentially bypassing the whole process and going to discuss with this person, this alternative person. All right. Okay, good. Let's move on to the next one then. I'll give you some time as well. Got some answers coming in, that's good. Very good. All right, perfect. It's really good. Thank you guys for being involved. Just very briefly, there was a question that was relevant about the previous scenario that I just want to touch upon. Somebody said, wouldn't it be better to do something active whilst complaining? Wouldn't C be doing something active whilst complaining is counterintuitive? Yes, I think that the nuance here is that you're involving someone who is just essentially completely unrelated. Even if you were to go to Robert's educational supervisor and you were to say, look, this is what's happening, their educational supervisor, they're not responsible for you, so they can't be particularly concerned about your educational development. They're not responsible for the ward, so they can't even, address the distribution of tasks on the ward. So they're essentially someone who doesn't really have much to do with the scenario, and you're pestering someone else. So even though you are doing something, you're doing something that isn't necessarily the best course of action, if that makes sense. So going back to this one, we've had quite varied answers actually, which I expected with this. The correct answer is DEBCA. I think the reason some of you answered the way you did, I can see why, is because I just mentioned in the previous question, it's best to address the person directly. Now, the small nuance that you may or may not have picked up on in this question is that it says here, what does it say this? It says, you did try to speak to her once about your concerns without success. Now that changes things, because it means you've tried to address this person before and they weren't having any of it. So automatically you're thinking, right, I've tried this, it didn't work. Am I just going to do it again? So if it's an ongoing issue, if it's a one-off, that's, you could try and speak to them directly. If it's something that's happened time and time again, and not only something that's happened time and time again, but something that you've tried to address and not been able to, then it's best to make someone else aware. So your consultant is probably the best person to make aware, because you're part of the medical team. So you would tell the consultant, look, this is what's happening. I just want you to be aware. You could even tell them, I'm going to try and deal with this myself, but just so you know, this is what's going on. The next one is ask your F1s if they've had similar problems with Jill. Again, that's not something that intuitively I would have said, that's really appropriate. But again, it's quite passive, and it's something that you could easily do, and just try and gather some more information, see if this is happening to anybody else, or if it's something that's exclusive to you, and then you can sort of do your due diligence to try and figure out why is this happening to you alone. B, inform the nurse in charge about Jill's comments. So a lot of you are right with the fact that the nurse in charge is Jill's direct superior, but you're part of the medical team. So you're having this problem with Jill. It's sort of debatable whether you keep it within your own team or you go directly into another team to make someone else aware. So my rationale would be you're making your consultant aware so that they just know early on what's going on, and they can give you some advice potentially. The next best step is to gather a bit more information, as someone said in the comments. You're just gathering information, which is good. B, again, is still somewhat passive. You're just informing the nurse in charge, again, about Jill's comments. C, you've tried it before, didn't really work. So you're just essentially trying something that didn't necessarily work again. Ask her what her concerns are with you, but it could work. A, continue to ignore. That's the worst, because you're not doing anything. So all the other ones, none of them seem to have a really negative effect. Obviously with C, if you were to find Jill, she were to get really annoyed, that might be counterproductive. But doing A, just ignoring the situation altogether is not up there. It's actually the worst option in this case. So if you want to have a quick look about the rationale, this is something that I'd really advise when you practice this by yourselves. Always go to the rationale that they give, and don't listen to what everybody else says, because you're inclined to, if you do SJTs as groups, you're inclined to listen to what other people are saying, what explanations are they giving. The truth is, nobody really knows. Even I don't know. I know what I thought in my mind, and I did okay. So, I know what helped me do relatively well, but that doesn't necessarily mean it's going to be applicable to every question. So the best thing that I think I did was I would keep going back to the UK FPO official guidance, their official rationales, and I would use that to guide my thought process. So let's go into another one. I'll give you some time as well. This is pick the 3 most appropriate actions. And remember, with this section, it's not or, it's and. So the 3 options that you pick, they need to work well together. Very good. So we're starting to get a few varying answers. Okay, so correct answer is ACE. Now let me just very quickly do this exercise where I want to take you through the question, tell you essentially what I think are the salient points. So confused patient is an intra-abdominal infection. They've got acute renal failure after a procedure. Instructions to the nursing staff are clearly written in the notes regarding what action to take if there's a change in urine output. When you get there in the morning, these instructions weren't followed and the patient has deteriorated. Okay, so that makes it more serious. The next thing is really important. The patient has received treatment. Okay, so the patient, according to this scenario, this has been addressed. The patient has now received treatment, but you need to do some follow-up. Okay, so you're an F1, remember this, you're not the consultant, you're not in charge of the ward, you're not the matron, you're an F1. Instructions were left, instructions weren't followed. It's somewhat been rectified because the patient has now received treatment, but now you need to do follow-up actions. So as an F1, what would you do? As I think someone described it really well in the comments, you're making different teams aware, okay? So you've made the nursing team aware of the incident. You've made the medical team aware of the incident, which is really important. So A and C are actually quite important. You're making someone in the medical team aware just because there might be a nuance to do with the treatment that you don't quite understand, and somebody needs to say, okay, look, we need to start this treatment now that the patient's deteriorated. And you're informing the nurse because from this scenario, this had to do with the nursing team, and also the nursing team are responsible for patient care as well. So you need to make the two of them aware. And then E, again, it's that information gathering. You're finding out whether the nurses were aware of the instructions regarding the changes to the patient's urine output, because if not, then you can hardly hold it against them. If there was, a really busy night, if you were understaffed, you're sort of trying to figure out what went wrong. And that's essentially the most important thing that needs to be done. Because, H, for example, ask the nurse to increase the frequency of observations on the patient. You don't know if that's necessary. Record your accounts of the night's events. Again, that might not necessarily be something that you're required to do. What are some of these other options? Inform the patient there was an error with the management of her condition. Right now, you're just essentially trying to troubleshoot, find information, and then you would speak to the patient about this. But that's not necessarily something you would just go and do without collecting a little bit more information. So there's that. And if you're wondering again about, I would always advise you go back to their explanation. This is all on the UK FPO papers, and try and read it, because the way they describe things are relevant. We've got one more scenario to do, to give you some time. Very good, getting some answers. Keep sending them in. Give it a little bit more time. Good, okay. All right, so very good. We've even got some people giving explanations for the rationale, which is great. It means you're all thinking. So again, I want to do that little exercise where I take you through the question, and I want to highlight the salient points. So it's 8 a.m. You finished a busy night shift on AAU, okay? So you haven't just been doing nothing, you've been working hard, okay? It's also 8 a.m., so you've just done a night shift. A patient of yours with acute renal failure needs blood tests to be repeated in 4 hours' time. So it's not like they need the blood test repeated now, which means that you could stay for 15 minutes and just finish this job. No, it's to do with the way you manage AKI. You need to take blood in 4 hours. So when you're thinking about this, A, for example, might sound like a sensible option, but actually to stay on the ward for 4 hours to wait to do the blood tests would be, pretty ridiculous if that was expected of you. So you approach your F1 colleague, he's starting his shift, so he's just about to start, and you try and hand it over to ensure the blood tests are carried out. Again, doctor to doctor, you're doing the right thing. He angrily says he's got a long list of other patients, he's just been called to an emergency situation, and he refuses to accept your handover. So I think a lot of you exactly explain the correct rationale. What's the first thing you can do? So this is really Jared's job. If Jared isn't coping, well, that's another issue. That's something that you need together to perhaps raise with the consultant. But his job right now is to take this handover from you, because you're an F1, he's an F1, so you need to hand over to him. So the first thing, the most appropriate thing to do, I don't think I've given you the answer. The answer is B, C, D, E, A. So the most important thing to do is to just explain to Jared, and again, the way it's phrased is a positive way. Because if you were complaining, if you were moaning, you're explaining to him, look, you're now responsible for the wards, so I really need to give you this handover. If you're busy now, don't worry, this just needs to be done in 4 hours time. So just add it to your list, make sure it gets done. That's perfectly sensible. So speaking to Gerard and asking him to do this. The next one, finding someone else, fine. If Gerard is completely overwhelmed, it's best to find another appropriate colleague. Why isn't C more appropriate than B? I think because of the way it's phrased, okay, and because Gerard's just started his shift, you can't start your shift. And when you start a shift, when you start working, I think this is one of the things that you pick up on when you're in the hospital a lot. When you start to work, you have to go for a handover. So for someone to be at handover and to be handed over a job that is completely understandably a job that needs to be handed over, and for them to say no when they've just begun and they're there for handover, you can't do that. So the most important thing is to explain this to him. Explain, look, just make a note of this. It's not something you need to action now. It's something you need to be aware of. So number one, explain to Gerard. Number two, find an appropriate colleague because at least it gets done. The next one is D. Okay, why is that not a good option? Because you're going to leave detailed instructions for him to follow up later. What if he forgets? You know, whose responsibility is that? So that's not necessarily appropriate. E, inform a nurse. Again, you know, nurses will often do a lot. I've worked in ITU and nurses do a crazy amount, but this is that you're breaking that chain of doctor to doctor by going doctor to nurse, which isn't ideal. And then the last one is to stay on the wards. You've just finished, it's 8 a.m. You might have another shift later on. It's not appropriate for you to sit around for 4 hours to just wait for, you know, for the bloods. So that's the rationale that I would have for answering this. And again, I'd advise go back to their own rationale because they often explain it well. So let's go on to I think this is the last scenario. Very good. Yeah, perfect. Give you a few more seconds. Very good. All right, so let's look at the right answer. B, C, E, D, A. I just want to say something very briefly about the last scenario because I got a question coming in. I got a few people asking the same thing. What if this other F1's been called to an emergency scenario? Again, this is one of those little things that you pick up on when you start working in the hospital, but if this guy's holding the crash bleep and he's called, that's different. He wouldn't be there in the first place to react angrily to you. He'd be gone. If he's not holding the crash bleep, with regards to these emergencies, he doesn't need to be there now. It's obviously not enough of an emergency that this guy can't, you know, this guy is essentially sitting around at handover, so they're there. It's not something they need to do now, so it doesn't delay them getting to the emergency. It's just something they need to make a note of, and in 4 hours' time, the emergency will likely be over. So it's about thinking through the scenario, and if you're the model F1, what would you do, but also having some common sense. Just because you've been called to an emergency doesn't mean you don't have 10 seconds to write down the patient's MRN and what needs to be done so that you remember it later on. Coming back to this. So let's do that exercise, reading the question together. Albert, a 70-year-old patient, was admitted mid-morning to the general medical ward. He's recently diagnosed with a brain tumor and he's come back to hospital for further tests. You've advised their family that an MRI scan be arranged within a few hours. The radiology says the MRI scan won't happen now until tomorrow morning and because of urgent cases. So now you need to tell the family and the family react angrily with you. This is something, you know, that unfortunately you're going to encounter a lot of in the NHS. So I think a lot of you answered this correctly, so I don't think this would be the most difficult question. So number one, all of you pretty much got this right. Apologize for the delay, listen to their concerns. That's the best thing that you can do right now. C, explain the clinical need for other scans. That could be perceived as somewhat confrontational. I know it's not phrased necessarily that way, but the reason B makes more sense is because I'm sorry, and then listen to them a little bit. And then maybe you can bring up that actually there is a clinical need for these scans and that's why there's the delay. But the most important thing, if you only had to do one, would be to apologize and listen to their concerns. Second best option might be to say, look, actually these scans are urgent. That's the only reason. So the information I gave you before was reliable. It's just, that's actually the next option. Advise them that the information was accurate at the time. You're not giving them too much insight as to what went wrong. You're just trying to cover yourself. Actually, what I told you was right at the time. So that's why it goes below C. And then it's D, inform about the formal complaints procedure. They haven't asked. So if they're just angry, oh, why is the scan not happening? Here's the formal complaints procedure. You can see how that would be perceived as dismissive. And finally, inform the delay is the responsibility of the radiology departments. That's not really appropriate because, the radiology department are doing their own thing. They're doing these emergency scans. So you can't just palm off responsibility. It's a shared responsibility. You were the one who told them the scan would happen today, and then it didn't. So actually the responsibility is shared between the two departments, not necessarily just to do with the radiology department. So let me just have a quick look. Formal complaints should be low as this isn't something you would want. Sure, but I think the way, I agree with you. I don't think you'd necessarily want to encourage a formal complaint, but it would depend on how you phrase it. So if they're really, really angry, maybe it could de-escalate the situation, just informing them that, this is the formal complaints procedure. If you're that angry, here you go. But just palming off responsibility completely and being like, no, that's, the radiology department's fault. I think that would, in this particular scenario, that to me would be the worst option that you could have. So again, read through their explanation when you've got time, and especially as you start approaching the exam. I think this is the most important thing most important snippet of information I want to give you. Listening to other people is great. Listening to my rationale is great. You start thinking about these things, but the most important thing is to listen to the actual mock papers. What do the experts say? Because this is the same type of protocol that's going to be put in place for your own questions. So this is a feedback form. We'd really appreciate it if you guys could just leave us some feedback. I hope you enjoyed the lecture. I don't know if guys, do you all want to log in your videos, including Zach and everyone, and then maybe we can go through some of these questions that we haven't quite addressed. If anyone's got any burning questions, it's going to be difficult to address specific questions, but hopefully we've given you the framework to start thinking about these things, because that's really the most important thing.
Yeah. Can everyone please fill out the Google form? It's for the TMEF guys. So they'd greatly appreciate it. They put a lot of effort in putting this together. So please fill out the form. Yeah. Do you guys want to go through the Q&A and answer the most pertinent questions that have come up?
Yeah.
Yeah.
So I've got one that I might feel to Satch. Where do we find these 5 domains? Is it in this GMC Good Medical Practice or elsewhere?
It's on the UK FPO SJT section, and they've listed it themselves. It's all taken from their website.
Awesome. I've got another one saying, in consideration questions, does social life always come last? I find this really difficult as there's an emphasis on work-life balance, but a lot of the official questions and consideration questions put social life last. Can you explain why? I think that's difficult to sort of try and generalize. I definitely wouldn't say social life always comes last. I think it's just that patient safety comes first. And then, so there's a few things that usually rank higher. So addressing the situation at hand, maintaining patient safety, these things usually come quite highly. So I think in the examples that we gave, the social life just happened to come last because it wasn't, in the whole grand scheme of things, it wasn't the most relevant. Having said that, if you feel like you're reading a question and the question is sort of leading you in the direction of you're really stressed, you've got no social life, you know, your mental health is starting to take its toll, then absolutely social life is really important. And that's something that you would, you know, you'd need to discuss with your educational supervisor and whatnot, and try and figure out how you can maintain that balance. All right. Guys, we've got one here. I don't know if anyone else wants to take it. Can you explain consent in under 16s? Under 16s can't refuse treatment. How do you think about parents? One of the pieces of advice I'd give here is that I know Callum mentioned in the beginning that there's some key knowledge that you need to have that you can get from good medical practice, but I don't think from experience, one of the guys can correct me if I'm wrong, you're not going to get some really, really difficult ethical scenarios. Usually it's somewhat straightforward, and you just need to have an awareness of what Gillick competence is, what's Fraser competence when it comes to contraception, and you know what are the cutoffs, and also it's going to very much depend on the scenario. Is this a sensible scenario? Are you doing something that sounds sensible?
And I think, just to piggyback on that, in this situation when you have such a difficult ethical scenario, your first option would probably be to refer to a senior or multiple seniors or the multidisciplinary team, the nurses in charge, to have these discussions about these scenarios. You're not expected as an F1 to handle consent for something, you know, major for a child. So be aware of these, you know, the Gillick competency and all of that, but just be aware of your, you know, your responsibility to escalate this appropriately as well.
Absolutely, absolutely. We've had a question from Omar asking how much preparation and how far in advance. I'd say that's very much up to you. I can talk about my personal experience, and I think most of these guys had the same experience. We were all at King's, so everything was quite clumped together. Final writtens, final OSCEs, AFP applications, you know, AFP interviews. So I didn't devote a huge amount of time to the SJT. I would say there's sort of a sweet spot. I would start thinking about it well in advance, like you're doing today. You're here now, you've listened to all of this, so that's a fantastic start. Start thinking about these things in your head, start familiarizing yourself with the concepts, but then you can really sort of crank it up a notch towards the exam. And there's not that many resources that you can do that are completely reliable. So I would say if you were to, you know, just think about things in advance, do some questions, familiarize yourself with the concepts, read the good medical practice. I'd say maybe 2 weeks before the exam, start going through these mock papers. Go through these mock papers 3-4 times each. Really read those answers. By the end, you can you've almost memorized the correct answer just when you're doing the question. So I don't think you need to start months in advance. Certainly not even a month in advance. I don't know, guys, if any of you have different advice.
Yeah, I would say something similar. With everything going on, I'll probably spend about a week or 2 weeks on it, and that I felt like that was probably the right amount of time to do the past papers once or twice and to learn the answers and learn the rationale behind the answers rather than just memorizing the answers blankly, because that might be quite dangerous as well. Yeah. If you do start memorizing the answers and then they could change 1 or 2 words that change the nuances of the question, and that could change the answers. So don't memorize answers blindly, memorize the rationale behind the answers, be flexible when it comes to the question.
Thank you for that clarification, Satch. Absolutely. That's really, really important. We've got a question about someone that failed. Why did they fail and did they pass the next year? I don't actually know anyone who failed.
I don't know anyone who failed. I think it's quite rare that anyone fails this exam. So I wouldn't worry too much about it. Just, I mean, one of the things that Callum mentioned that's very important, just answer every question.
Yeah.
And that's probably the most important thing to not fail the exam or get a really low score.
There's actually a funny story. I won't mention any names because I don't know if they'd be happy with me sharing this story, but in our year at King's, there was someone who got this is a true story, who got the time of the exam wrong and actually arrived 35 minutes late. They were somehow still allowed to sit the SJT, and they sat that exam in an hour and a half or something, and they still passed. So that just goes to show that if you prepare and you've got good time management skills and you can read quickly, you can still pass. All right. Are there any other questions that you guys have picked up on that?
Yeah, people asking, is there a way to practice the new section? There is an online paper which has a lot of these new questions available. We've tried to, we did take some of the questions there as you saw in the paper before, but I think if you have a registration, you might be able to do it and then they can give you responses and the answers to that. We weren't able to get the answers because of we don't have an account, or we weren't able to register an account for this. So there is definitely past papers to practice a new section, as well as the old papers to practice the old ones.
Somebody asked, what's the difference between, or do you go to your clinical supervisor or educational supervisor? They don't quite understand the difference. Does anyone want to take that one?
Yeah, sure. So I think some medical schools will do this as university students, so you get used to it. Some of you might not have experience with it, especially if you're from abroad as well. Your clinical supervisor changes every rotation. So every 4-month placement, when you're in foundation years, you have a clinical supervisor who will be from the team in which you're working, a consultant from that team. Your educational supervisor stays with you for the entire year and is more responsible for your general academic progress, looking at your portfolio throughout the year. So principally any concerns that relate to the immediate clinical environment and the working of the team would go to the clinical supervisor, whilst anything that affected your long-term performance, your well-being, your ability to attend educational courses and needs as per your portfolio requirements would go to your educational supervisor rather than the clinical supervisor.
Awesome.
I think I saw a question about, have you got any advice for when the rationale seems to contradict itself in the official mock papers? I think this is probably something we have all come across, especially if you do more questions than just the official mock paper. And I think the best way to approach it is, it doesn't necessarily contradict itself. It's very dependent on the wording of the question and the subtle differences in how they word the question. So I would really sit down, try to understand what the question is asking, and think about the rationale, and think about how you would apply that to other questions. And I guess one thing I would say is, this is not like a standard exam, like a written exam where, you know, you can aim for full marks. You may not get every question right, and that's absolutely fine. It's about time management. It's about answering every question. It's about the way me and Miguel discussed answering the questions, thinking about the domains, and really maximizing your chances. And you know, you will come across some questions that you think may contradict itself, but just think about what it's really asking, and even discuss it with other people, because that's really helpful as well.
A couple of people asking about previous books and things. I'd say any other resource apart from the past papers are probably not as reliable as the past papers. The official ones are the only ones we can reliably say this rationale will stand true when it comes to the exam. Any other books or PassMed or eMedica, other things I've seen in the questions, it's totally up to you what you do, but I'd just say take any rationale or advice they give with a pinch of salt, and try and always come back to the UK FPO guidance in terms of what you think is the right rationale for any questions.
Awesome. Somebody's asking, can you change your rank for deanery after you get your SJT results? I don't think so, no. I would say I think my view has always been go for it, and whatever happens, happens. So don't necessarily rank a low deanery because you're scared of the SJT, because you never know what's going to happen. So just go for it. Somebody also asked, by 2 weeks of prep, do you mean full time, as in 2 weeks, but nothing but SJT? Absolutely not. Absolutely not. At least that certainly was not the case for me. If you wanted to do it full time, I kid you not, and you won't hear me saying this about any other exam, you could probably do it in about 3 days. Just because if you get into that, you know, mindset, it's genuinely not about memorization. It's not about practice, because there's only so much you can practice. It's just about having that thought process, knowing, you know, what usually comes first, being fresh on the day, you know, having a nice coffee in the morning, sleeping properly, being nice and alert, really good time management. That's really important. So definitely practice time management. That's the main thing, but don't obsess about spending ages on the SJT, because in my view, it's a bit of a waste of time. There's other things that you could be doing that are much more important.
Someone asking about how much time to spend on each section. I would say if you find that you need more time or you require less time on a particular section, then divide your time accordingly. But personally, I spent time according to the proportion of marks that were awarded for each. So if it was 60% of the marks in the paper, then I spent 60% of my time on that.
Yeah. I think my technique as well, this doesn't work for everyone. I would have a particular pace that I was working through the SJT with. If there was a question that I was stuck on, I wouldn't stop myself and get stuck. I would circle it, move on. My priority was just blitz out the whole paper as quickly as possible. And it actually meant I managed to go through the paper like twice, because anything that was getting me stuck, I wouldn't hesitate on it and waste loads of time. Leave it, move on. You know, write what you think is on the paper, or when you're doing it at home, just write a scrap piece of paper, what you think is the best, what you think is the worst, move on, come back to it later. Just make sure you finish the exam. That is the most important thing.
And it's definitely worth practicing timing. Do a full exam in the time allotted, because in many ways it's a time management paper, or, you know, exam by attrition, in that you will read a lot. It'll be very tiring. So practice a full exam and practice answering every single question.
Yeah, absolutely. I think that's it, really. Tips on how to get 45 points, please. Should, not would. I think most of the things we've covered, but ultimately, unfortunately, I think I still think this is quite an arbitrary exam. When my results came out, and I think it was the same for all of these guys as we discussed it, we were all happy, like quite happy, but you know, if you told me the mark that I got, or if you told me a mark that was 10 points lower, it would have been the same to me, because I had absolutely no idea how I did when I left the exam. And I think you'll feel that way as well. You're going to leave the exam, people are going to ask, how did it go? And you're going to say, I don't know. And then when you get the results, hopefully you're going to be happy, but you're not going to feel, you know, any more confident about that type of exam. It's just one of those exams. People are asking about when to do it. Before what sitting. Look, I think that very much depends on you. I would say try and do it at a time where you can focus just on this, at least for the couple of days before, so that you really get into that mindset. Don't stress yourself out. So do whatever, you know, pick whatever timing works best for you and your university timetable. Try and sort of manage it that way.
I guess there's quite a few questions asking specifically for Kings and other timings. When we did it, we did the previous versions, and that was determined by a university, so we didn't have to pick our dates. Our date was given to us, and it was arbitrary. So at least you guys have a bit of a choice, I guess, and just, I think, base it around your personal timetables and what suits you best is going to work.
Yeah, absolutely. Awesome. I think the only last question that keeps coming up is regarding going through good medical practice. I would say, you know, I would say do it, especially because you're going to feel bad if you don't do it. I did it. I don't think it really helped me, because in my particular exam, I don't think there was anything that required knowledge that I didn't already have. Having said that, I did learn a few bits and bobs from good medical practice that were important. And had they come up, I'd have felt really bad not having just gone through it. But I wouldn't say, you know, study it, make notes. Absolutely not. Just literally sit down, go through the whole thing. If there's anything you don't know, just try and commit it to memory. But the whole thing is going to take you a while to go through, and you're literally probably going to pick up, you know, maybe 10 facts that you didn't already know that are concrete things. Everything else is just commonsensical somewhat. It's just things that you should already know, and you probably already know.
And someone asking about whether we can order the good practice on like the paper copies. We used to be able to, but I think because of COVID, it's not probably a thing anymore. But there was an app on mobiles that you could download, and you can go through the good medical practice on your phone. So
there's a PDF online as well. If you just Google good medical practice, you can read the PDF.
Yeah. Awesome. Zach, I might hand over to you.
Brilliant. Thank you so much, guys. Remember, everyone, please fill out that Google form. It'd be really helpful for Miguel, Ahmed, Sachan, and Callum. Some housekeeping stuff. We do have a lecture tomorrow at 3 p.m. with Dr. Azim Harlim on primary biliary cholangitis and primary sclerosing cholangitis. And another lecture on Monday on pediatric gastroenterology. I don't know if you guys think we can do another webinar on SJTs. What do you guys think? Or, oh yes, the TMEF guys do want to do AFP interview talks soon. Do you want to discuss that very briefly, Miguel, Ahmed?
Yeah. So what we're doing this year is we're actually delivering the AFP curriculum for a couple of universities in London. I think what would be good for us to try and do is see if one of the universities is kind enough to allow us to open that Zoom or Microsoft Teams or whatever software we use to everyone. I think I might need to have a word with the rest of the trustees. We're definitely going to make sure you follow our newsletter because we're definitely going to try and do something because there's been a lot of demand. So hopefully we'll give it an AFP lecture and an AFP workshop. And somebody just said, please make it free. Absolutely, that's what we're all about. So it'll definitely be free, definitely.